Well, good afternoon, everyone. This is Mike Hill coming to you again for part 4 of our webinar series, our 5-part webinar series on the anatomy of a self-funded health plan. Glad that you could join us today. I'm going to dive right in so we can stick to our timeline and have this wrapped up by 12:30. And I think this particular topic might be a little bit lighter than previous ones, and so we should wrap up a little bit early, actually. So I'm going to share my screen and dive right in and take you through part 4 of the anatomy of a self-funded health plan. And our focus today is on medical management, which is one of the more nebulous topics when it comes to managing a health plan, specifically a self-funded health plan, and one of the most overlooked components of health plans. And so I have a lot to share with you, and we could certainly go a lot deeper, but want to give you a good overview of what I'm talking about when I say medical management, what you should be thinking about, and some kind of insights into the whole concept as a whole. And just as a preview, in June, we'll be coming back together again the last Wednesday of June to talk about stop loss as we wrap up this series. So today, when we're talking about medical management, what I want to do first is define it so that we can all agree on what it means. And that's actually going to be really hard to do. So we'll take you through a couple different definitions of what medical management means, depending on who you're asking, what the primary role of medical management is and the various components of it, the different models of medical management, and then discuss how you determine which one's right for you. And again, just to recap, stop loss will be back here on June 26th to have that conversation. So diving into what is medical management. As I mentioned, medical management is a very nebulous topic, and it's depending on who you ask, you're going to get a different answer. And if you ask them 3 weeks later, you might get a different answer again. What I wanted to do to drive that point home was just show you 3 different definitions from 3 different players that touch healthcare in different ways and what their definition is. And I just randomly picked these to kind of drive home the random points that the definitions are very arbitrary. But TRICARE is a government-sponsored plan. It's the health insurance plan for the folks in the military. And as far as TRICARE is concerned, I'm going to read these to you. I realize it's not ideal, but I want to just try to drive some key points home. So TRICARE is saying medical management is the purpose of it is to establish programs or systems that improve clinical outcomes and manage rising healthcare costs. The 3 major components of the TRICARE medical management program are case management, disease management, and utilization management services. Got it. Pretty easy to understand. Well, let's see what McKinsey thinks. So you might be familiar with McKinsey as a international consulting firm that touches almost every industry and often is the high-powered consultants that come in to help a particular industry improve. And we'll circle back with McKinsey here in a couple of slides as well. But McKinsey defines medical management and care management, which are often interchanged terms. They define care management as any payer-driven effort. So a payer, again, is an insurance company or a third-party administrator in a self-funded plan's case. So any payer-driven efforts to engage with the targeted members and their care ecosystem to encourage and enable high-value decisions around their care and improve self-management. Okay, well, that sounds good. Well, what about Aetna, one of the largest commercial insurance companies in the country? What do they think about medical management? What's the purpose of theirs? And the goal of the Aetna medical management team is to promote cost-effective care, going back to TRICARE, again, talking about cost-effective care that helps members be as healthy as they can be. This means working with providers to assess conditions, create care plans, coordinate resources, and check progress. Got it. So a lot of similar themes, but different overall reasons for existence. And so there are a number of different terms that came up in the TRICARE component that also often show up in other definitions of medical management. So I wanted to talk about those as well. So medical management and care management, oftentimes they're interchanged, but they can also mean different things. So let's talk about utilization management and review first. So utilization management and or utilization review, used interchangeably, is a process that evaluates the efficiency, appropriateness, and medical necessity of the treatments, services, procedures, and facilities provided to patients on a case-by-case basis. So when you hear this particular term, think dollars and cents. This is the folks that are going to be ultimately paying the bill, wanting to make sure that they're paying the appropriate bills and that we're not jumping from an X-ray to an MRI when an MRI is not appropriate. We're not skipping step 1. We're going to go 1, 2, 3 versus going from step 0 to step 8, for example. So that's kind of making sure that's the mother may I component of a plan. Case management is a process in which a trained professional, which is often a nurse, helps the patient develop a plan that coordinates and integrates the support services needed to optimize the healthcare and psychosocial possible goals and outcomes. What did I just say? This is the point where, let's say I am diagnosed with cancer. And so I'm going to be interacting with the healthcare system for quite a long period of time, going from point A diagnosis to hopefully point B, which is where I am in remission or cured of the particular issue. And so there's going to be a lot of steps through that process. And what case management is a healthcare provider, or excuse me, a healthcare payer, assigning a trained professional, oftentimes a nurse, to work with someone to help them manage their particular situation to get the best possible outcome as quickly as possible, making sure someone's looking at the big picture and connecting the dots. And then finally, disease management is more focused on not just one particular something that comes up. I'm in a car accident or I'm diagnosed with cancer. That's case management. But disease management is maybe I've got a chronic condition like diabetes. I'm a type 1 diabetic. I will be forever and always unless they figure out a new cure. And so how do we manage that condition to make sure I'm keeping my numbers where they should be? I'm leveraging all the resources available to me to make sure that I'm as healthy as I can for as long as I can be. So that's disease management. And these sound very similar to one another and they often overlap. But these are unique components of an overall medical management program. So let's talk about the role of medical management as a whole. And I've just borrowed these particular graphics from one of the industry solution partners that you could choose to partner with your self-funded plan, the care management company, because I thought they did a pretty good job of overlaying what the overall purpose is. If we think about someone's interaction with the healthcare system, if I'm a patient and I'm interacting with the healthcare system, there's many different medical providers I might interact with. If I'm in the hospital for an extended period of time, every 8 hours or so, a different team is coming in, and I might need to be referred to a specialist or a different facility for different purposes. And it's really challenging to have one person or one entity overlooking the entire big picture. And ultimately, that's the original intent of medical management, to make sure that we're connecting all the disparate dots within a particular healthcare experience. And on the left-hand side, these are all the various different medical providers or solutions that I might interact with when I'm dealing with my health insurance plan. And again, we want to make sure the right hand is talking to the left. So that's what medical management's attempting to do. But in addition to that, there are many other community resources or tools available to me as a patient that may be outside of my health plan, but could improve the overall experience. And so we want someone paying attention to that as well. There could be, maybe I need to get legal support for one reason or another. I was injured on someone's property and we need to try to get their insurance to pay. Or maybe it's, you name it. I can't get from point A to point B because I'm in a wheelchair and I don't have a vehicle that can support that. So how do I get to my appointments? All of those types of things. Those are all various components of a holistic medical management program that ultimately we would want to play a part in any health plan that exists. So that's the reason for medical management, why it exists. But let's take a look at the different models. And the bottom line is there are dozens, if not hundreds, of different medical and or utilization management and care and case management and disease management models that are out there. We basically can choose our adventure and solve any problem we're trying to solve with different solution partners that are out there today. But depending on where you're getting your health insurance and who's helping you manage it, you may not be able to pick the solutions you want. So let's talk a little bit about how we get the medical management solution that we have with our health plan. So who decides what the program looks like? If I have a fully insured health plan, the fully insured carrier has made the determination of what moving pieces and who's going to be on the team to be part of the medical management program. They very well may employ a team of nurses that are helping with the disease management and the case management. They may be playing a role in the utilization review to make sure that, hey, we're getting the right care at the right time and we're paying the right price for it. So a fully insured carrier may employ all those folks or partner with third parties and bolt them onto their plan, but they're making that determination. If we're self-insured, but in an ASO model where we're using a commercial insurance carrier to be the administrator, same story. They're generally going to be bringing their solution that they use in the fully insured environment to deploy that across your self-funded plan as well. And then finally, if you work with an independent TPA, you might be making the determination of who the various players are that you want to hire and why. But also there's another influence on who the players are going to be, and that's the network of providers that you use. We've talked about how we access providers in different ways in one of our previous sessions, and depending upon what network we use, for example, if I choose to use the Cigna network that I can bolt on with an independent TPA, they're going to dictate certain components of what my utilization review looks like and who I can and cannot partner with. And so there's no right or wrong answer there, but there are other folks that may influence the decisions that you make as well. So let's dive into these a little bit more and talk about the pros and cons. So in a carrier model, again, they're determining who the players are, and it generally feels pretty seamless to the member. They don't know if it's a third party or an employee of the the health insurance carrier that's interacting with your folks. So it feels pretty seamless because it's all generally in-house, or it all flows through one kind of point of entry. The downside about these approaches is generally we will have limited reporting, and often it can be a delayed response from the time that something starts to the time that their team may actually deploy the resources and engage with the member. And ultimately, it's really hard for the employer to play a supportive role in this. And we'll talk about the alternative and why you may want to in a moment. But ultimately, it's a, hey, take our word for it. We're the professionals. We have this under control. Yes, we have these solutions, and basically don't ask any questions. Some examples of what this looks like. So I had insurance through a commercial insurance carrier a few years ago when I found myself in the hospital with my daughter, who was having what we thought was an asthma attack. And we spent the night in the hospital, ultimately got her under control and got home. And about 4 or 5 weeks later, I got a letter in the mail from the insurance company. It was a boilerplate. Hey, we think that your daughter might have asthma. Here's some things you can do. Let us know if you want any additional support. At that point, 4 or 5 weeks later, it was kind of out of sight, out of mind. We had a plan in place. We knew what was going on, and I never followed up with them or said anything to them. And part of the problem with that is that they didn't know about it until the claim was submitted by the hospital. The hospital had to take their time, get it submitted. They had to process it, and then the various flags had to go up, and it had to get assigned to somebody to reach out to me and send the letter. So that's certainly one model that exists. We've had many other examples of where we think that case management or care management should be engaged in a particular situation, and we reach out and it simply the trigger hasn't been pulled, or it's in the queue, but it's going to take a while for it to happen. And that's simply because, in commercial insurance carrier model, there's a lot of claims flowing through and a lot of individuals that they're trying to figure out who to reach out to, and with very limited resources. And so, yes, they have these programs. Yes, in many cases, they're good and supportive, but there are some downsides to it. If we look at a TPA model, on the other hand, there's downsides too, just like everything. But what are the differences? Generally, highly customizable. So we have a lot of flexibility in who we work with if we're working with an independent TPA. We can go in search of all the moving pieces. Who do we want to use for disease management? And do we want to specify, diabetes, and we want to hire somebody specifically for diabetes to be part of our disease management program? We can take it to the nth degree. There's one component we're going to talk about more. It's that utilization review, the prior authorization process. We could choose an independent player for that. But if we use a particular insurance carrier's network, we may be limited on who we can work with. There's a much greater level of transparency. So we can find out, depending on who we partner with, who they're reaching out to, how many times they've reached out to them. Did they have any success in making contact? They called 5 times, never got an answer, so they made it a cold case, for example. Or yes, they reached out in these ways, these times, and the interactions have been this, and this was the last time the conversation was had, and here's what the game plan is. So you can get a lot of detail if you want to know exactly who's doing what and is the desired effect being met. And this also gives you, the employer, to play an active role, again, making sure we're playing by the rules when it comes to HIPAA and so on, but making sure that if somebody's not engaging, we know that, and we can then encourage or incentivize the participant to engage so we can get them the support that we truly believe would be beneficial to them. The downside of this approach, though, is it can be very clunky because an independent TPA may not have this solution in-house. So we may have different phone numbers for pre-certification or for our diabetes or for our large case management or whatever it happens to be. There can be lots of cooks in the kitchen, and it may not feel like a streamlined process. And so that can make the member experience more clunky and something that they might be less inclined to engage with potentially. So there's certainly some thoughts that needs to go into that and needs to be managed well. Okay, so let's talk about the ROI of these programs. We know we're trying to integrate these things and make sure we're connecting the dots and the right hand's talking to the left and we're helping people get as better as possible, as quickly as possible. So are we really getting the ROI? And as I mentioned, we're going to circle back with McKinsey. Back in 2021, they did a study on insurance payers' medical management programs and their efficacy and what they could do to improve them. And again, I'm going to read to you here because I think this is important, and this talks about McKinsey's philosophy or take on medical management. That in McKinsey's experience, many payers, so insurance carriers, TPAs, are dedicating 10% or more of their administrative costs to care management, but they're not seeing an ROI on it. These payers have traditionally expressed more confidence in other levers to keep costs down, such as utilization management, meaning the mother may I, can I get this or can I get that? The payment integrity, meaning when a bill shows up, is it an appropriate bill? Are there some shenanigans going on and we need to edit that bill and make sure we only pay for the appropriate things? And then finally, the network. Hey, we're going to try to negotiate better discounts, and we're going to use those three tools to keep costs under control. And actually, medical management / care management's really kind of an afterthought, or we're really not getting any ROI on that. Well, McKinsey believes there's opportunity for health plans to reinvent what medical management or care management looks like and to get a better effect from that. And they're pointing out two primary reasons that a payer, you as a self-funded plan or an insurance company, might want to do this. And if we look at the items on the right-hand side, if we're the patient or the healthcare provider or the payer or the insurance company that's trying to make a profit, all of the things on the right-hand side in the dark blue or black, I think are things that we would all agree are important. We want to avoid things that are preventable. If we can keep somebody healthy longer or make sure that something bad wasn't missed, we want to do that. And so that makes sense for everybody, and no one really can argue with that. Site of care, are we getting the person to the right place as quickly as possible to get the best possible care and keep this person on the right trajectory to get healthy? Yes. Making sure we're paying the right fair price for something when we get it. So yeah, that makes a lot of sense. And that we're getting the appropriate treatments and we're managing this thing well. Things aren't falling through the cracks. Those are all things that McKinsey believes are appropriate in a next generation care management program. I think we would all agree those are important. The items in the lighter blue, though, are opportunities to maybe make some more money or potentially keep some money in your pocket if you're a self-funded plan. Are we getting the clinically appropriate items in? Is it being billed correctly? That goes to that payment integrity again, too, is making sure that what's being done is actually is the right thing, that we're not missing anything, that no things are falling through the caps, there's no gaps. And then if you are a commercial insurance company and looking to make a profit, there's an opportunity through this process to sell more product to either the employer that's providing the plan or to the individual member. And so there's some reasons that we may or may not agree with, but McKinsey believes that if we have a program like this in place, we can deliver anywhere from 2 to 5% cost reduction from having a well-managed program like this in place. Okay, great. So how do we improve it? What are the things that we need for a next generation care management program? Well, I've put a red box around the real key point here. So first and foremost, in today's program or the next generation, we're targeting 15 to 20% of the patients that interact with the plan. For folks that are going to the primary care doctor on an annual basis, that type of thing, they don't need the outreach. So it's only 15 to 20% of the population today or in a next generation plan we're going to reach out to. The key thing, though, is how many people we actually engage with. Today, it's only 10 to 30%, and we want to see that increase as high as possible, but ideally at least 40 to 60%. If we drive increased engagement, we're going to see increased cost reduction, which is good for the plan. That makes a lot of sense. And the administrative cost to have a next generation plan or today's plan is really the same. We're not going to spend any more money, but if we modify this and manage these things more tightly or are more thoughtful about how we do it, really focusing on the engagement, we can get a 2 to 1 ROI or more on the dollars we invest here. So what is the ground zero then? From our perspective is how do we drive that engagement? We've talked about utilization review, and a component of utilization review is the prior authorization process. Prior authorization is also known as pre-certification or pre-authorization or many other names, utilization review. And what is it? It's basically when a health plan or an insurer requires approval, mother may I, before a patient receives any health care, prescription, or other treatment. This allows the plan to determine, number one, are we getting the right care at the right time? But number two, it allows the whole process, it's the first domino in the process to get all the other components of a medical management plan rolling. And so we think it's very important, but also Man, it is a double-edged sword, and we're going to talk about that in just a minute. One thing that I really want to share with everyone is one of the key things that was so eye-opening for me 5 or 6 years ago when I learned about MCG. MCG Health used to be known as Millman Care Guidelines, but now they go by MCG. And it is this massive database of all different health conditions under the sun that's constantly updated with the best evidence-based guidance on how we treat something. And just to give you an example of what it looks like, and why this is important is that of the top 10 largest commercial insurance carriers in the country, so all the big players, the big blues, the Aetnas, the United Healthcare, Cignas, and on and on and on, they use MCG when we're determining what's the appropriate level of care, what should somebody be getting today, right now, and what should they be getting 6 hours from now. And this is a really important tool because in the heat of the battle, when something's happening, we know that healthcare providers are doing their best, but things evolve at a high rate of speed and things can fall through the cracks. And so we believe with prior authorization, pre-certification, there's an opportunity to be a second set of eyes to make sure we're getting the right care. And where is that coming from? Is that just, an insurance company trying to save a buck, or what are they looking at? And in many, many cases, most cases, it's MCG. This is an example of a myocardial infarction, otherwise known as a heart attack. And what I want to just share with you is what this thing looks like. And it's like 20 pages long, and we're going to go through it at a high rate of speed. But what they're saying is that in the event of a heart attack, day one, someone should be in the ICU. And their clinical status will include various things to indicate, yes, they've had a heart attack, and yes, they should be there. What should the patient be doing? What types of treatment should they be getting? What sort of interventions? And what sort of medications, for example? By day two, where should they be moved down to in an ideal scenario? They should be moved down to a different lower level of care. And day three, where should they be going? And we should start talking about discharge, actually, and getting them out the door. So this is the ideal scenario. And you'll notice there's a ton of footnotes here supporting all these recommendations. So how long should we be there? About 2 days. Well, what if we need an extended stay? What would be the trigger for that? And again, what's the supporting evidence-based guidance to make sure that that's the right course of treatment for this particular person? And we'll talk about while they're in the hospital, what things should they be doing? Are they doing an EKG or ECG? Are they doing coagulation tests and so on and so forth to make sure nothing's fallen through the cracks? Type of interventions and so on. Again, all the supporting information on where these recommendations are coming from. And then discharge. Making sure that, hey, if I live by myself and I just had a heart attack, are they just going to send me home by myself, or do I have someone there to support me? What are the things that we should be doing now to make sure that this person gets as healthy as possible moving forward? Once we get this discharge done and we talk about this destination and so on, then we're getting into the evidence. And this is the part I really wanted to share with you. There's all the supporting information and all the studies in all the various journals. And this is one's a couple years old, but it's constantly updated. So in particular, New England Journal of Medicine study in 2017, here's how they support what things we should be doing. But we're not just relying on that one study. It's study after study after study. And so this is something that I think is very important for folks to understand, that when a healthcare plan is trying to do the prior authorization, the utilization management, yes, there's a financial component to it, and we can certainly talk about that. But also there's the attempt in many cases to make sure that nothing's fallen through the cracks and the patient's getting the best possible care. It's just a second set of eyes. This thing continues to go on and on and on with footnotes and additional substantiation on all the things that they're recommending. So this is one example of MCG, and I think it's just really insightful to know that this is happening behind the scenes, and many insurance companies are using this in different ways. Some use it just to say no, others use it to be proactive to make sure that, again, nothing's fallen through the cracks. So scrolling through this just again to show you the depth of the information just for a heart attack, for example, it can get really, really in depth depending on the condition. But this too is a double-edged sword. So we take a look at what's happened in terms of growth of physicians in the healthcare system and administrators over the last 50 years. And this is from 1970 to 2009. Look at the amount of overhead related to administration that's happened to the healthcare system. And why is that? Well, if you're a hospital, you got to employ a bunch of people to be on the phone all day, every day, making sure that the insurance companies are going to pay them if they do something to a particular patient. And on the flip side, you've also got the health system or the health insurer that needs to employ people to do the same. So certainly there's a bureaucracy involved with this. And what it does in the U.S. healthcare system, we spend more on administrative costs than the other developed countries that we would otherwise compete with. So that's not an ideal scenario. When we look at what providers are spending when they spend administrative dollars, what percentage are tied to dealing with health insurance related expenses. For physicians groups, it's about half of their administrative expenses are dealing with just insurance companies. For private insurers, it's almost all of their administrative expense. And hospitals, it's almost half again. So this is it's a wonderful thing and it makes a lot of sense. And we want to know as soon as possible and help people get the right care, but it also brings a lot of bureaucracy to the table. And what that means, people don't like it. It slows things down. And the member doesn't like the experience either. So a couple other things. The Kaiser Family Foundation just released this study from 2021 that Medicare Advantage plans, commercial Medicare plans, there were over 35 million prior authorizations submitted in 2021. And of those, only 2 million were denied. So for those 2 million that were denied, maybe that made sense and we saved money and helped somebody get the right care. But that means 33 million requests were made that were ultimately approved. And maybe that was unnecessary and slowed down the process, added administrative hassle to folks, frustrated the patient, and also drove up the bureaucracy and cost. So the question is, what is the right model and how do we go about doing this? And how do we tie everything together, but do so as efficiently as possible? Well, people are paying attention. Legislators in various states, 9 states recently have passed bills that are trying to fix the prior authorization process or eliminate it altogether. It's also being reviewed at a very high rate of speed at the federal level. So the prior authorization tool and the way that comes into starting as the front door to engage in overall medical management is going to evolve over the next few years and do so pretty significantly in many cases, we believe. So last slide here for you. What is your goal? What should you be considering with medical management? As I mentioned, there are a lot of components to it. If you shop for a third-party administrator, they may provide parts of it, or you may shop others. But oftentimes in our experience, when an employer is shopping for a health plan, this is a topic that does not come up or very little attention is given to it. And it can have a huge impact on how your plan performs from a member experience standpoint and also from a cost standpoint. And so our recommendation to you is to make sure that as you evaluate your next health plan or your current one, you better understand what medical management means to your current health plan and why it is that way. And think about what are the priorities you're focused on. Are you trying to contain costs? Is that really what your number one driver is? Or are you looking for someone to really connect the dots and coordinate the care and make it a smoother member care experience overall? Or are we looking for member accountability? If there's tools that can help the member have a better experience and get healthy faster, and we know that it's been proven by objective evidence, then we should have them engage. And if they don't, do we want to drive more member accountability and have them have more skin in the game if they're not willing to be part of the solution? A medical management plan can help you do that. Or are we just trying to make it a simple member experience? We want it to be easy peasy when people engage with the healthcare system, and we don't want them to have to jump through hoops. All of those are worthwhile objectives, and many employers want all of them. Depending upon how you want to structure your plan, your medical management plan or components can really influence this and actually be ground zero for all of these items. And they all have pros and cons. So we really want to encourage you to dive more deeply into what this means to your particular plan. Why is it the way it is? And is it meeting your goals? That, in a nutshell, is medical management, and we could go a lot deeper, but it is an important component, and we appreciate you spending time with us today. So I'm going to wrap it up and look forward to seeing you back at this time next month, the June 26th, to talk about stop loss as the final component on our anatomy of a self-funded health plan. Thank you for being with us today. Really appreciate it. Have a great day.